Okay, welcome back to osseous tissue. This week we're going to finish up osseous tissue and we're going to go over chapter 7 and 8 are the axial and appendicular skeletons. So starting off with the formation of the bony skeleton, 6 weeks after fertilization of an embryo, cartilage starts to form and it turns into bone after about 8 weeks in utero. Some bones don't stop growing until the age of 25, so there will be different ossification centers for each bone, and they will fuse at different times in your lifespan. Ossification or osteogenesis is the formation of bone. Calcification is the deposition of calcium salts. So calcification and ossification are not the same. Ossification is the formation of bone. Calcification is calcium salts, and calcification can happen in other tissues as well as in bone. Endochondral ossification and intramembranous ossification are two types of ossification or bone formation. Starting off with endochondral ossification, this is when bone replaces cartilage. So this happens during growth spurts. There's two different types of growth that happen during endochondral ossification, interstitial and appositional growth, and we'll talk about those in just a second. This is when the development of a primary ossification center happens within cartilage. So this is when bone is going to form at the center of cartilage and become bone from the inside out. The timing of this ossification can be measured by the widths of epiphyseal cartilages in long bones. So these are your growth plates, and in adults you have an epiphyseal line, so it can show where those bones fuse together. In interstitial growth, the bone is growing in length, so we'll have secondary ossification centers develop. These primary and secondary ossification centers determine the shape of the bone, as they will determine which parts are still dividing and growing and which parts are done growing. Epiphyseal closure is when that growth plate closes, so when those cartilages just come together to form bone. The timing will differ on the bone and also on the individual. Some will have longer growth spurts than others, making for differences in height and bone length. In appositional growth, this is bone growth in diameter. So this involves the formation of a bone collar within the cartilage. Osteogenic cells or bone stem cells will differentiate into osteoblasts to create bone. When those osteoblasts have created bone surrounding the cell themselves, the osteoblasts themselves, they will eventually become mature bone cells or osteocytes. In intramembranous ossification, this is our second type of ossification. This happens in the embryo. So osteoblasts will differentiate in mesenchymal or fibrous connective tissue. This is also known as dermal ossification because these bones are also known as dermal bones. This happens deep in the dermis. So your skin and everything is already formed when these bones start becoming bones rather than cartilage. So the skull bones, mandible, clavicles, these are all considered dermal bones that will undergo intramembranous ossification to become bone tissue. We also have an abnormal type of ossification, heterotopic ossification. This happens in non-skeletal tissues, so we'll form bones in tissues that aren't supposed to have bones, or at least not in those places. So myositis ossificans is a genetic form of this heterotopic ossification, and it can occur in any tissue where bone will just form. It could form in a large piece of bone, it can form a small piece of bone, but regardless, it's in places where the bone shouldn't be. Traumatic myositis ossificans is the most common out of these three types. This happens after an injury to soft tissue, so in response to soft tissue, instead of forming scar tissue in its place, sometimes the body will form bone tissue. And neurogenic heterotopic ossification is due to some sort of spinal cord injury. They're not really sure about the pathogenesis of this right now, but there's still research out on it. There is a lot of blood and nerve supply to bone. Going down the center of the diaphysis is the nutrient artery and vein. They run through the nutrient foramina. The metaphysis itself is supplied with blood through the metaphyseal vessels. The periosteum contains the periosteal vessels, the lymphatic vessels, and sensory nerves. So lymphatic vessels will help to drain any excess fluid in the area, and the sensory nerves will provide sensation, pain sensation, things of that nature, to the periosteum. Bone remodeling is the idea that our bones are constantly being recycled and renewed due to the components of the bone matrix. So they can change shape, they can change our internal architecture or mineral content. A fifth of our skeleton is recycled and replaced every year. So we're constantly getting rid of old bone, replacing it with new bone. And because of that, we have this interplay of osteocytes, osteoblasts, osteoclasts working together to remodel these bones. With weightlifting, so there's this law called Wolff's Law that states that the more stress that's put on bone, the more bone will form. So bone will form in places where there's constant stress on bones. So people who weightlift have bigger and stronger bones than somebody who doesn't, because they're constantly putting stress on those bones. Heavy metals like lead, cobalt, radioactive uranium, or plutonium resemble calcium in structure, so they can be incorporated into bone matrix by accident, making bones radioactive and contributing to cancers. This is why it is so important to make sure that you're not constantly exposing yourself to things like lead paint and other heavy metals that can result in poisoning yourself. So we already sort of talked about this with Wolff's Law. Stress bones become strong bones. They become thicker and stronger. So it's quite the opposite with degenerative change, or with inactivity. So if you're inactive, the bones will start to degenerate and lose their mass. And bones vary depending on your age, depending on your sex, depending on your race, and depending on your health. So people who specialize in forensic osteologists, they can tell the person's age, sex, health, race, depending on their bones. There are a lot of nutrients and hormones that contribute to bone health. Some of the minerals, the most important minerals are calcium and phosphate by far. Getting enough calcium and phosphate in your diet. Also, other microminerals that are important: magnesium, fluoride, iron, and manganese. Calcitriol is a hormone that's produced by your kidneys, and it helps to allow your digestive tract to absorb calcium and phosphate from your diet. So even if you're taking in enough calcium and phosphate, if you don't have calcitriol, you won't be able to actually absorb it. And calcitriol is formed from vitamin D. So if you're vitamin D deficient, you're not getting enough sun, you will also not be able to absorb enough calcium and phosphate from your diet. Vitamin C is responsible for collagen synthesis, so it's really important in preventing things like scurvy, which can weaken bones over time. Vitamin A stimulates osteoblast activity, especially in kids, and vitamins K and B12 synthesize proteins that are really important for bone growth. Growth hormone also does protein synthesis in bone growth. Thyroxine is produced by your thyroid. It increases the rate of osteoblast activity, so again, making bone. Sex hormones, especially when they're in high amounts during puberty, help to stimulate osteoblastic activity as well, so that's when growth spurts might occur. And we'll talk about in just a second how parathyroid hormone, or PTH, and calcitonin work in functioning to fluctuate the calcium levels in your body. So calcium is the most abundant mineral in your body. The regulation of calcium ions comes from parathyroid hormone and calcitonin. So think when calcitonin tones down the amount of calcium you have. So it lowers the amount of calcium that's going on in your blood by putting it back into bone. Parathyroid hormone raises the amount of calcium that you have in your blood by releasing it from bone. So calcium ion regulation is really important for muscle cells to be able to contract your muscles, neurons for nervous impulses, your plasma membranes. Even a 50% reduction in calcium ions can cause death. It's that important to regulate the amount of calcium in your body. The target sites for calcium: bones, digestive tract, and kidneys. So we already talked about this a little bit, but parathyroid hormone effects on bones. It indirectly stimulates osteoclast activity, so it breaks down bone to release that calcium into the blood. So it'll increase the amount of calcium ions absorbed by the intestines by enhancing calcitriol secretion, and it decreases the amount of calcium ions excreted by the kidneys, so we have more calcium free floating in our bloodstream. And here's a diagram showing the effects of parathyroid hormone. Calcitonin does not increase osteoblast activity, but rather it inhibits osteoclast activity. So while the other one indirectly stimulates osteoclastic activity, calcitonin is going to inhibit it. Calcitonin and vitamin D3 levels raise during pregnancy because we are using these hormones to create bone in the embryo. So calcitonin can be used as a treatment for postmenopausal women who end up getting osteoporosis. And here's a diagram showing calcitonin's effects. Some abnormalities of bone growth. Gigantism is an increased amount of growth hormone prior to puberty. So this can result in very tall individuals, but they tend to have a shorter lifespan. Acromegaly is an increase in growth hormone after puberty, usually later on in life. This will result in not just a taller individual, but they tend to have lengthier fingers and toes, bulkier skulls, and really prominent jaw ridges. Marfan syndrome is an increase in collagen synthesis or cartilage growth. Marfan syndrome we'll talk about in the future with other organ systems, but it can cause a lot of issues with other organs, specifically the heart, where it can cause too much elasticity in the aorta, resulting in an increased incidence of things like aneurysms. And fractures. So fracture is a break of a bone. An open fracture is a fracture that when the bone breaks, it protrudes through the skin and it's open to the environment. A closed fracture is a break where the bone remains in the body and not protruding through the skin. A transverse fracture occurs in a transverse plane, so straight horizontal fracture. Usually that's due to some sort of pathology. Normal people don't get transverse fractures. Usually there's a disease process at hand. A compression fracture occurs from an axial load. So if you have too much strain from superior to inferior, that can cause a compression fracture. Usually this is used to describe fractures in vertebrae. A spiral fracture is exactly what it sounds like. It occurs in a spiral pattern in bone. This is usually more of a sports injury. Epiphyseal fractures occur in the epiphysis, and these are extremely important things to consider in especially pediatric populations who might still have epiphyseal plates, growth plates. So if the growth plate is disturbed, this fracture has to take special consideration from the orthopedic doctor in order for it to heal properly so the person can continue growing in that bone. Comminuted fractures occur when a bone breaks in multiple places. A greenstick fracture is a bending or buckling of the bone, usually in pediatric populations where the bone matrix is a little bit more flexible than those of adults. When fractures heal, first they form a hematoma or a large blood supply surrounding the fracture. This will promote healing. Callus formation comes next. A callus is immature bone, so it forms a temporary bone in its place. Spongy bone formation happens next, where trabeculae form, and then compact bone forms last. Osteopenia is a term that means a weakening of bone or a less dense bone matrix over time, usually with age. This can also occur in people who have immobilized bones for long periods of time if they fractured it and it was in a cast. Usually they'll be a little osteopenic following that, but with bone remodeling and use of that bone again, it should return back to its normal state, if not stronger. Bones typically become thinner and weaker with age. Usually begins from ages 30 to 40, so if you're approaching that or you're in that age bracket, your bones are already becoming weaker. Something you can do to combat this is weight-resistant exercises, doing weight training, because as we said, people who weight lift tend to have stronger bones as they are stressing them more often. Also, running will help a lot with that too, with the bones in your legs, to keep them nice and strong from the impact. Women lose 8% of bone mass every decade, men lose 3%, so it's no shock that women are way more at risk for osteoporosis. So osteoporosis is a more significant form of osteopenia. It's called osteoporosis because it looks like pores have formed in the bones. They have become so weak. This especially occurs with postmenopausal women due to a loss of estrogen. So estrogen is something that helps to promote bone growth. So after menopause, we don't make as much estrogen as we did in the past. It's really important to supplement that estrogen with hormone replacement, or there can be implications with osteoporotic changes that can result in really easily fractured bones. Bone marrow cancers can also cause osteoporosis. Men also get osteoporosis, but the most common is with menopause. So now we're going to go into the axial and appendicular skeleton. What is the axial skeleton? It's everything that's down the middle of your body. Your skull, your thoracic cage, and your vertebral column. It has none of the limbs and none of the limb girdles. So that would include the shoulder girdle and the pelvic girdle. So no scapula, no clavicles, no hips. Everything down the center is the axial skeleton. There's about 80 bones in your axial skeleton, which makes up about 40% of your skeleton. I know this looks like a lot of you, but a majority of you is actually in your appendages, your limbs. So the axial skeleton helps to protect your brain, your spinal cord, and all of your thoracic organs, and it provides a lot of attachment from muscles, which we'll talk about next week. The skull contains 22 of those bones, 8 of which are in the cranium, and the skull bones also include the auditory ossicles, the stapes, the malleus, and the incus, the tiny bones of your middle ear. And you'll have 14 bones of the face, so let's talk about those. In this picture, you can see the frontal bone separated from the parietal bone by this coronal suture. The parietal bone is separated from the temporal bone by the squamous suture. And the occipital bone is separated from the parietal bone by the lambdoidal suture. Anterior to the temporal bone, we have the sphenoid, which can be seen in both the orbit and on the lateral side of the skull. And then you'll also see the ethmoid in the orbit, just posterior to the lacrimal bone. We have the hyoid bone, which is also included in this, and that is found within the throat, just underneath the mandible. It's actually the only bone in your body that doesn't have any articulation, so it doesn't attach to any other bones. It's free-floating in the muscles within tendons. The bones of the face, some of them are the nasal bone that forms the bridge of the nose, the lacrimal bone that sits just on the medial side of your orbit, the zygomatic bone or zygomatic arch, that is what forms your cheekbone. The maxilla, that forms the upper part of your jaw. The vomer, which is kind of hard to see here, you can see it on either side of the nasal cavity or on the posterior surface of the face, which we'll see in a different view here in a second. And then we have the jaw. The lower jaw is the mandible. So here's some more views. We can see the posterior view here. So you can see the parietal bones on either side, left and right, separated by the sagittal suture, and separated from the occipital bone by the lambdoid suture or lambdoidal suture. From the superior, you can see the frontal bone, the parietal bones, and the occipital bone, and this is a good view of all of the sutures. Coronal is in the coronal plane, sagittal is in the sagittal plane, and then lambdoidal is in the back. From the lateral, you can see the mastoid processes here. The external acoustic meatus as the hole that goes into your ear. The styloid process. Anytime you see styloid, that means pointy. So it's this pointy process that comes off the temporal bone. Of the zygomatic arch, you have the zygomatic process of the temporal bone and the temporal process of the zygomatic bone. So the temporal process goes toward the temporal bone, zygomatic process goes toward the zygomatic bone. And this is a good view where you can see the lacrimal bone and the ethmoid just posterior to it. Posterior to that is the sphenoid bone, which you can see through the orbit as well. Just superior to the orbit, you see the supraorbital foramen, and inferior to it, you see the infraorbital foramen. We can also see a couple of parts of the mandible here. The holes on either side are the mental foramen or foramina, and the bumpy part at the anterior surface of the mandible is the mental protuberance. From the anterior view looking into the orbit, you can also see the sphenoid, which is both sides on either side of the superior orbital fissure, this larger hole through the middle. The more circular hole medial to that is the optic canal where the optic nerve travels. The inferior orbital fissure sits between the sphenoid and the inferior part of the orbit, which ends up being part of the maxilla. Here we can also see the vomer and the perpendicular plate of the ethmoid. We can also see nasal conchae here, inferior and middle. From the inferior, we can see the foramen magnum, which literally means large hole. On either side of that are the occipital condyles. It's where the first vertebrae sits. We have the mastoid processes on either side of that. We see the styloid processes coming out. The palatine bone on either side here, and the palatine processes of the maxilla on either side here. We see the vomer down the middle, and we can see the different components of the zygomatic arch as well. We also have sinuses within our skull. They are air-filled chambers, and they help to lessen the weight of the bone. They also are resonating chambers for speech, so the different sizes of the sinuses contribute to how your voice sounds. And they're lined with mucous membranes, which is how they can get infections. Here's another view of the orbit. Fontanelles are found in small babies, infants. They're necessary for rapid brain growth, so there are these what are called, usually colloquially called soft spots. Without these, the baby's brain would not be able to grow sufficiently. So you have 4 different fontanelles. You have the posterior fontanelle. It's back here. It closes at around 2 to 3 months after birth. You have the sphenoidal fontanelle around the sphenoid bone. It closes around 6 months after birth. The mastoid fontanelle, which closes around 6 to 18 months old. And the largest and last to close is the anterior fontanelle, which closes around 12 to 18 months old. The anterior fontanelle, if you were to palpate it on a baby, you would be able to feel a pulse there because it covers some major blood vessels. It's also used to determine dehydration, so you can see a little sinkage of that fontanelle if a baby is dehydrated. A lot of first-time parents might get a little scared upon seeing that because it looks a little wild. In the vertebral column, it's split into 5 sections. We have the cervical vertebrae, thoracic vertebrae, lumbar vertebrae, sacral, and coccygeal. There are 7 cervical vertebrae, 12 thoracic, 5 lumbar, 5 sacral, which are fused together, and coccygeal varies depending on the person. Fun fact is that most mammals have 7 vertebrae, including giraffes and whales. You also have, some people might think that the spinal column is straight, but it actually has all of these curves that are really important for the function. They can be characterized as primary or secondary curves, depending on when they were formed during development. So your thoracic and your sacral curves are both called primary curves because you're born with these. You're born with these, what are called kyphosis, where they have these posterior curvatures of the vertebrae. The secondary curve is the cervical curve and the lumbar curve. The cervical curve starts to develop when the baby can hold its head up by itself. So it develops this lordosis when able to hold the head up. The lumbar curve forms when the baby starts to walk by itself. It's important to remember where your center of gravity is, depending on if you are a male or female. Men tend to hold their center of gravity more straight over their body, where women tend to hold their center of gravity further forward. So knowing where your center of gravity is will help you in not hurting yourself or hurting your back when lifting things or reaching for things. Your center of gravity just shows where the most force will go upon a load being put on your spine. So the cervical and lumbar curves are known as lordosis or lordoses if plural, and a thoracic or sacral curve, the posterior curve versus the anterior curve, is a kyphosis. So let's talk about some typical vertebrae. Typical vertebrae meaning that most of these vertebrae look the same. There are some that are abnormal, like C1 and C2, which we'll talk about in a second. All typical vertebrae have a vertebral body. They have pedicles, which attach the transverse process to the vertebral body. They have inferior articular facets, where they join with the vertebrae below, and superior articular processes, where they form facets with the superior vertebrae above them. The vertebral foramen is the larger hole in the middle that allows the spinal cord to pass through, and the spinous process is the part that sticks out. If you palpate with your hand down the center of your back, you'll be feeling the spinous process. So this is showing how these vertebrae connect to each other. You can see the facets here. So this is an inferior articular process with a superior articular process. So inferior of this vertebrae with the superior of this vertebrae, and that's how they connect. In between each vertebrae is an intervertebral disc. This is filled with fluid and allows for shock absorption so that these bones don't collide. It's a type of fibrous cartilage. And it has a jelly-like fluid in the middle. So if you have a herniated disc and that fluid leaks out, usually the back or lateral sides of the disc, that can cause a lot of inflammation and pain, especially since you have nerves that are coming out of either side of the spinal cord, on either side of the vertebrae. So if that fluid leaks out, it can irritate that nerve as well. And here are some abnormal vertebrae, the cervical vertebrae C1 and C2. So here you can see a typical cervical vertebrae. Some of them have bifid spinous processes, which means that instead of coming out as one spinous process, it diverts into two. So it's just called a bifid spinous process. The transverse foramen is where blood vessels and nerves leave the spinal cord. Again, the vertebral foramen is where the spinal cord will pass through. And it has all of the other parts of a normal vertebrae. This is C1 and C2. C1 is also known as the atlas, and C2 is known as the axis. As you can see, the atlas does not have a vertebral body. It more so has arches, so it has an anterior arch and a posterior arch. No spinous process. It has a transverse ligament that holds the dens in place. The dens is a part of the axis, or C2. So this helps with rotation of the neck, but the transverse ligament is extremely important in making sure that these two vertebrae stay together. If that dens gets dislocated from C1, it can result in serious trauma. In people with rheumatoid arthritis or Down syndrome, this ligament tends to be a little loose, so it's really important to keep that in mind with different clinical implications if you go on to be in the medical field. Whiplash occurs when you have a sudden jolting force, which tosses your neck into flexion and then backwards into extension. So you can see here the bottom of your cervical vertebrae is hitting the first thoracic vertebrae, which can cause a lot of pain. And moving down into the sacrum. So as I said, there are 5 sacral segments that are fused. There's an entrance to the sacral canal where some of your nerves like to sit. They also have an articular process on the top where they articulate with L5, the 5th lumbar vertebrae. They have sacral foramina, be posterior, and these would be anterior, depending on your view. At the bottom is the sacral hiatus, and then the coccyx is your tailbone, which attaches to the bottom of the sacrum. So abnormal spinal curves. Remember I said that a kyphosis and a lordosis is completely normal in your spine, unless it's a little bit more exaggerated than it should be. So remember, you're supposed to have a kyphosis in your thoracic spine, which would be here. But sometimes it becomes a hyperkyphosis or excessive kyphosis. And that's generally colloquially termed a hunchback. This can happen for a variety of different reasons. It can happen with tuberculosis. It can happen with different fractures or degenerative changes. A lot of diseases occur that can cause a kyphosis. A lordosis. So remember, lordosis is normal in the lumbar and cervical spine, but sometimes it becomes a hyperlordosis. These can also be hypokyphosis or hypolordosis, where they are not pronounced enough and can cause problems. A lordosis becomes a hyperlordosis often during pregnancy because you have this increase in growth in your abdominal region, your spine has to accommodate so that you're not falling over with all of this added weight. And then a scoliosis is always abnormal, and this is a lateral curvature of the spine. You can see that it kind of goes off to the right and comes back to the left. This can cause a lot of issues, especially in the thoracic cage with all of your thoracic organs. Sometimes they develop less on one side than the other. Maybe a lung will be smaller than the other lung because it doesn't have a lot of room to grow, and things of that nature. So I've been talking a lot about the thoracic cage, but what is it? So it's where the vertebrae attach to the ribs, and the ribs wrap around and attach to your sternum. So this whole thing is known as a thoracic cage because it looks like a cage. It's a cage that holds in all of your thoracic organs. So first let's talk about the sternum. The sternum has a jugular sternal notch on the top, and it has three parts: the manubrium, the body, and the xiphoid process. In red here are cartilages, so we have costal cartilages. Costal means ribs. You have true ribs, false ribs, and floating ribs. True ribs are ribs 1 through 7. True ribs because they attach directly to the sternum. False ribs are ribs 8 through 12. And they are called false ribs because they don't directly attach to the sternum. They attach via cartilages that attach to other ribs cartilages. And then you have floating ribs, ribs 11 through 12. So you can see here how they attach to a vertebrae. This is a rib attaching to a vertebrae. There are joints. These are the posterior transvertebral joints that attach the ribs to the vertebrae. You have the head, neck, and angle of the ribs, as well as a tubercle. The body of the rib is the main portion of the rib. You have a costal groove and an angle. So that was all the axial skeleton. The appendicular skeleton is composed of your limbs and your girdles, your pectoral girdle or shoulder girdle and your pelvic girdle. So this is the remaining 60% of your skeleton. Everything over here that's not in yellow is your appendicular skeleton. Think appendages. So your pectoral girdle is composed of your clavicles and your scapulae, not your sternum. There is a want of people to include the sternum as part of the shoulder girdle, but remember the sternum is a medial structure, so that's included in the axial skeleton. So you see that the clavicle attaches to the sternum as well as the scapula at the acromion process. It's a really small bone. It's smaller than people think, and it ends up being the most commonly broken bone in the body. Then we have the scapula, or your shoulder blade. This is an anterior view of the scapula, so you have the superior angle, this pointy part. You have the medial border, the lateral border, the inferior angle, just to get you oriented. The subscapular fossa is this main depression on the anterior side. The coracoid process points out anteriorly, and the acromion process is posterior to that, and it's what attaches to the clavicle. You also have the glenoid cavity or glenoid fossa, and that's where the humerus is going to attach. And the glenoid cavity or glenoid fossa has a supraglenoid tubercle on the top. You have the spine of your scapula in the posterior view, which separates the supraspinous fossa from the infraspinous fossa. And here you can see the acromion process and the coracoid process just anterior. Moving on to the humerus. So we have a greater tubercle and a lesser tubercle of the humerus. It has a head and an anatomical neck. as well as a surgical neck. This is just differences between anatomists and surgeons, where they like to call the neck of the humerus. This is the shaft of the humerus, also known as the diaphysis. So this is the epiphysis, metaphysis, diaphysis, or the shaft. The deltoid tuberosity is a rough process on the surface of the humerus. And you'll also see a radial groove where the radial nerve passes. The main curly part of the humerus at the bottom, the inferior portion, is known as the trochlea, the part that points most inferior. And on the other side is the capitulum. You'll know what the lateral and medial epicondyles are depending on where the head is pointing. So the head is pointing toward your shoulder joint, which would be medial. So the medial epicondyle comes out on the side where the head is pointing. And the lateral epicondyle is opposite. If you flip the humerus over, you can see the olecranon fossa, which is a deep groove in there. That's where the olecranon of the ulna will sit. We also have a smaller depression on the anterior surface known as the coronoid fossa, and the radial fossa on the lateral side. This is the ulna and the radius. The ulna always has this notch in it. So the olecranon process, or the olecranon, is this outer portion that forms the notch. The notch itself is known as the trochlear notch. The ulna also has an ulnar tuberosity, which is a rough portion of just inferior to this trochlear notch. There's a coronoid process that comes off of the end of the notch, and a radial notch sits right below it, and that's where the radius will attach. In between the ulna and radius here is the interosseous membrane, which just holds these bones together. It's just a cartilaginous sheath. And both the radius and the ulna here have a styloid process that points off. And remember that styloid means pointy. So the pointy process off the radius and the pointy process off the ulna are the styloid processes. So on the practical, make sure that you specify which styloid process you're looking at. Moving on to the carpals, metacarpals, and phalanges. So let's start from the posterior view. We see the scaphoid, which is closest to the radius, lunate, and triquetrum. Above that is the hamate, capitate, trapezoid, and trapezium. I always like to remember trapezium is on the thumb. For the metacarpals, you would name them depending on which finger you're looking at. So from the thumb, medially, 1, 2, 3, 4, 5. And then with the phalanges, they are proximal, middle, and distal. With the thumb, it only has a proximal and a distal, no middle phalange. On the anterior view, you can also see the pisiform, which hangs off of the triquetrum. Moving down to the pelvic girdle, we have the bones at the hip. By itself, it's known as an os coxae, and it is actually 3 bones fused into one. So we have the ilium, which is this entire piece up here. We have the ischium, and we have the pubis. So all 3 of these bones come together to form the acetabulum, which is where the head of the femur sits to form the hip joint. The iliac crest is the roughened part of the top of the ilium. We also have on the anterior side of it, the anterior superior iliac spine and the anterior inferior iliac spine. They form a much smaller notch here. This is usually abbreviated ASIS and AIIS. If you're feeling the front of your hip, you can actually feel your ASIS. You also have a posterior superior iliac spine and a posterior inferior iliac spine, usually abbreviated PSIS and PIIS. The posterior superior iliac spine, you can also feel if you're palpating your back. It's usually where if you have back dimples, that's where your PSIS sits. Just inferior to this PIIS is the greater sciatic notch. It's where the sciatic nerve will pass through. And inferior to that is the ischial spine. Inferior to that is the lesser sciatic notch. The big hole in the center is known as the obturator foramen. The big roughened part on the ischium is the ischial tuberosity. And then you have the ischial ramus that meets with the inferior pubic ramus. The superior pubic ramus, and there's a pubic tubercle. The pelvis itself is both hip bones, both os coxae, coming together with the sacrum. In between the pubis of either side is the pubic symphysis. It's a fibrous cartilaginous joint. Sometimes this can separate during pregnancy and cause a lot of pain. We also have the distinction between the true pelvis and the false pelvis. The false pelvis is anything between the iliac crests on either side before it reaches the pelvic inlet. The pelvic inlet is just the opening to the pelvis from the superior view. Anything below the pelvic inlet to the pelvic outlet is the true pelvis, and the pelvic outlet is just the opening to the pelvis from the inferior view. Going into the femur, we have the head of the femur, the neck of the femur, we have the greater trochanter and the lesser trochanter, the shaft or the diaphysis. There's an adductor tubercle, a medial epicondyle, a medial condyle, a lateral condyle, and a lateral epicondyle. Remember, epi means above, so it means that it's above the condyle. And the medial condyle and epicondyle will always face toward the head of the femur, because this is the point that's going into the hips. This is the patella or the kneecap. So the patella has a base and an apex. Apex means pointed surface, and base is more broad. And this is where the kneecap would sit on top of the femur. Below this is the tibia and the fibula. It again has an interosseous membrane separating the two and keeping them together. The tibia has a medial tibial condyle and a lateral tibial condyle. Remember that the fibula is on the lateral surface, so the lateral condyle will face toward the fibula. There's also a medial malleolus, but no lateral malleolus on the tibia. There is one on the fibula, but you can see if these aren't articulated on a practical, you would know that the medial malleolus is on the same side as the medial condyle. So the pointed part at the end of the fibula is the lateral malleolus. These are what are going to form the bumps on either side of your ankle. Then we have the bones of the ankle and the foot. The calcaneus is your heel. It's the biggest one of the tarsals. Above that is the talus. This is where the tibia and fibula roll on to create motion in your joint of your ankle. The flat bone above the talus is the navicular. The square-shaped one is the cuboid. And then the rest are cuneiforms, lateral, intermediate, and medial. The metatarsals are named the same, just like the metacarpals, 1, 2, 3, 4, and 5, depending from if you're going from big toe to little toe. And the phalanges are named the same as well. And phalanges in singular terms are called phalanxes. You call it a phalanx. So just like the thumb, the big toe only has a proximal and distal phalanx, and the rest have proximal, middle, and distal. We also have different arches of the foot. We have a transverse arch that runs in the transverse plane. There's a longitudinal arch, which comes in two parts of a medial longitudinal arch and a lateral longitudinal arch, depending on which side of the foot that you're on. There's also some differences in skeletons if you're male or female. There's also differences depending on races as well. So for the skull, for males, the skull tends to be heavier and rougher. It's about 10% larger than that of females. They have more sloping foreheads, larger sinuses, larger teeth, and they tend to have larger, square, more robust mandibles. In the pelvis in males, they tend to have narrower, rougher, and more robust pelvises in general, more vertical iliums, longer sacrums, and a deeper iliac fossa. Their pelvic inlet will be heart-shaped versus a more circular pelvic inlet for females, which is really important for childbirth. Males have an anterior pointing coccyx instead of an inferior pointing coccyx for females. This is also important for childbirth because if it were more anteriorly pointing, it would break off when the baby passes through the pelvic inlet. Males often have a more lateral acetabulum versus a more inferior acetabulum for women. Men tend to have a more oval obturator foramen versus a triangular one in females. And males tend to have a pubic angle less than 90 degrees versus a pubic angle of more than 90 degrees in females. Overall, men tend to just have more dense bones, a greater bone mass, and they tend to have more prominent bone markings.